Done with the macroinvasive papillary carcinoma. So let's get to more important things. Um, yeah. Next question.
Mm. That is E,
I say D.
E, the last one.
Yes.
E,
Um,
do you know what it is? Deletion.
yes. What do you think is deletion?
Hmm?
Yeah, I will call it, I say D, but let's see. What do you think is what is the deletion?
What is gynecomastia?
Yes. Okay, master. Okay. Let's see.
There is a similar lesion in female. Do you know what it
Oh,
is?
except the answer is actually E. I don't know why.
Yes.
Oh, why would I put in D? I don't know. Because we need to accept issue. This is the answer. This is wrong. Oh,
Yeah, he is the answer.
oh.
Do
Okay.
you know the name of the similar lesion in female?
No, what's it called?
It's called gynecomastoid hyperplasia.
Yes, I've read. Okay. What is the histologic finding of organic master? Describe the histology of organic master.
Mm, you see, what's the dilated ducts with
No lobules, right?
no lobes, and the duct in this case is lined by multiple layers of epithelium, and then is surrounded by a fibromyxoid stroma.
Okay. Let's quickly look. Don't worry, because you are the one here. Let's quickly look at this one. These are just two things. This prophylaxis surface, right breast mass. This is a right breast mass specimen surgically removed from a 16-year-old boy with gynecomastia. Showing a fibrofatty surface, cut surface is homogeneous and gray pink. The specimen weighs 87 grams and measured 8.7 cm. That's huge, man. Proliferation of mammary ductus. Low power view shows early stage gynecomastia characterized by increased number of ducts surrounded by loose, pale appearing periductal stroma. Pseudoangiomatoma hyperplasia, PASH of gynecomastia is shown here. Characteristic features of gynecomastia are shown, including loose periductal stroma, loose periductal stroma, and ductal hyperplasia. This is ductal hyperplasia with tapering tufts of epithelium. The ductal hyperplasia. Perfect, that's all. And let's quickly go to
The document you just read now, is it a book or an online
the online subscription.
material? Mhm,
Online subscription, a program subscribe for us.
mhm.
It's like a more comprehensive, the paid version of pathology outlines. Something like that. But for survey, it's easier to navigate and more comprehensive to an extent. I don't know. But that just said it's as good as but this one is like it's paid, so they try to make it more valuable. The pictures are very I have so many pictures. You'll be using it going forward, sure. And actually my
Mm.
program this one is they pay $1,000 per resident to use it. That's 1.20 million naira or how many pounds. So if you don't log in after a while, they know they don't like it. So that's why I have to log in once a day. So um actually if we fail, it should be it's not good because we are giving so many resources. Unlike you guys are able to do very well, despite the fact that you have limited resources. So what is gynecomastia? Define it.
Is a genetic proliferation
There are three components of gynecomastia.
ducts in usually in males.
Proliferation of male breast tissue. What are the three characteristics? That's what an ordinary
Increased number of ducts,
ductal
then
epithelial
duct
hyperplasia,
epithelial
tumor
hyperplasia,
proliferation, and periductal edema.
periductal edema.
Yeah, this place they look like patch. Let me see. Periductal edema. Okay, may not be there in everybody. Let's continue. So, what causes it?
There's hormonal now.
What hormone in particular?
Hormonal imbalance, estrogen stimulation outweighs androgen suppression.
Yes.
Then
For some reason, somebody begins to have a lot of estrogen. That's bimodal age distribution.
yeah,
Puberty and older men due to
my mother,
boys,
yeah,
often transient in boys, then older
puberty and
aging, medications.
elderly men.
Example of a medication that can cause it.
Okay,
Popular, not popular, spironolactone. Whereas aldosterone antagonists that is used as a
no
potassium
control.
diuretic. It's anti-androgen. This can cause gynecomastia. Many medications that
Hello, Jonah.
uh,
Jonah, can you hear me?
I can hear you. So it's also seen in newborns due to maternal estrogen exposure. Like my baby now has little tiny. And the said I was so resolved by the name of God. So um and anti-androgens, spironolactone, yes, glutamine, separate. I don't know, actual doctors inhibitors. Um ketoconazole, yes, anabolic steroid. Okay. Clinical presentation is firm subareolar, often bilateral breast mass. It's often bilateral. Take note of that. Can it be unilateral? Can the mass be unilateral? Hello? Melissa, are you still there? Hello? Hello, sir.
Mm.
Are you still there? Hello? Okay. Hello, sir. Hello. So what is the a clinical presentation? Can it be bilateral or can it be unilateral?
Mm, yeah, because usually bilateral, but you can't rule out
Traditionally, it can be symmetrical.
unilateral.
When I was Saudi Arabia, I had a case of gynecomastia. I referred the case and was just worried unnecessarily. Guess what? In that case of gynecomastia, I wasn't worried. I referred the case, and the patient was later found to have testicular tumor. Wow! I didn't even examine the scrotum, but I just referred for gynecomastia. Gynecomastia arises from imbalance of estrogens and androgens. Increased estrogen activity will lead to impaired estrogen metabolism. Okay, activity will lead to liver cirrhosis, can impair estrogen breakdown, and therefore increase the amount of estrogen acting. Testicular tumors like what testicular tumors can cause gynecomastia?
Certainly,
Certainly
cell
lead,
tumor
lead,
lead it.
leading, I don't know, but I would say certainly leading, but cell tumors, okay. But they wrote it there, so we can believe them. Hyperthyroidism, because that will increase sex hormone binding globulin, which increases more estrogen binding. Estrogen therapy for prostate cancer. Decreased androgen activity
Okay.
like Klinefelter syndrome, testicular failure, drugs like spironolactone, cimetidine, digitalis, ketoconazole, and anabolic steroids. Gynecomastia involves three histologic phases. One, early florid phase. Two, intermediate, late fibrotic phase. So describe the histologic features of the early florid phase of gynecomastia.
Let me see. Fluorine intraductal hyperplasia, periductal stroma, cesareity. That's, I think the one we saw in that diagram may be
Yeah.
similar to it.
Yes.
Periductal stroma, intraductal hyperplasia.
The intermediate phase, what is intermediate phase?
Reduce epithelial proliferation, then increase fibrosis, then less edema.
So what are the late phase?
Uh, that's dense periductal stroma fibrosis, atrophic ducts, then regression in the epithelial hyperplasia.
Now, you notice that, like we said earlier, we don't usually have lobular formation because male
Mm,
breast typically lacks what? Lobules. Rudimentary lobules can form if estrogen activities are persistently high. Epithelial cells are typically estrogen receptor positive. Okay. Let's look at patients with this condition do not have increased risk of breast cancer. True or false?
true.
Mm. In contrast, Klinefelter syndrome, which can cause gynecomastia, does increase breast cancer risk. So in case of Klinefelter syndrome, breast cancer risk can be increased. Take note of that.
That's true.
This lesion has a bimodal distribution that includes puberty and old age.
Yeah,
Middle age men on medications. Maternal estrogen and newborn period can also occur. This is the most common lesion identified in the male breast. True or false?
true.
What are other male breast lesions?
have lipoma,
Mm.
can have fat necrosis, you can occasionally can have carcinoma.
1% of all breast cancers. Well, the early forms of this lesion show florid intraductal hyperplasia, which may be mistaken for carcinoma, and that's true because there's prominent epithelial hyperplasia, proper and cribriform patterns may occur, stroma edema, hypercellularity may occur. Gynecomastia lacks atypia, necrosis, or invasive growth. Gynecomastia is never found in females.
Hmm?
Gynecomastia is never found
It's
in
not you don't call it a master in female, but you can have a similar a lesion that look like
yeah,
gynecomastia.
gynecomastia-like changes can occur microscopically in female breasts, especially under hormonal stimulation, e.g., pregnancy, lactation, hormone therapy. Female gynecomastia-like hyperplasia, that you're right, that's what we call it, right? Gynecomastia-like hyperplasia, right?
Yeah, some people call it gynecomastoid
Hyperplasia.
hyperplasia. It's still the same.
It shows ductal and periductal proliferation, resembling the male lesion, although in women it typically lacks clinical significance. PR positive gynecomastia microglial markers showing intact microglial cells, excluding carcinoma. Pseudogynecomastia is also called what? Lipomastia. They have
Gynecomastia.
without glandular proliferation and they occur in obese men. Male breast carcinoma is irregularly firm and sometimes with nipple retraction discharge. Last epithelial layer is regards cytology, papillary neoplasm, true epithelial proliferation with complex capillary architecture and atypia. Okay. Gynecomastia, the thing is that pseudogynecomastia is caused by lipomastia. There's no true glandular proliferation and Klinefelter syndrome can increase breast cancer risk because small testes and infertility.
Mhm.
Let's see if we can quickly get it done. And we are done. Don't worry, we are done with this question in the next few seconds or few minutes. Maybe 1 or 2 minutes. You have nothing. Mm. You have money. Which of the following best describe gynecomastia histologically? Three.
Which of the following best describe histology? The introductory hyperplasia. Yeah, the
The three stages of gynecomastia.
three stages: early flowering, intermediate, and late fibrotic stage.
What phase of gynecomastia is most likely to be confused with carcinoma?
Early flowering.
Which of the following is true about age distribution of gynecomastia?
Mother,
What is the most common lesion identified in the male breast?
gynecomastia.
Which hormonal imbalance underlies gynecomastia?
Sorry, maybe excess estrogen over androgen.
Which of the following drugs are associated with gynecomastia?
Digitalis.
Vitalis, cimetidine.
By
Oh. What is this?
testosterone system.
What is pseudogynecomastia?
Best fight the pollution without granular proliferation. Lipomastia.
Master. Do patients with gynecomastia have increased risk of breast cancer?
No.
What percentage of adolescent boys are affected by gynecomastia?
Thirty to 60.
Yes. Which receptor is most commonly positive in gynecomastia?
Estrogen.
Which of the following conditions associated with gynecomastia?
Extensive lobular formation.
Hyperparathyroidism. How does it happen? By increased production of sex hormone binding globally. that increases the total amount of circulating estrogen. Which histologic finding bound estrogen? Which histologic finding is not typical of gynecomastia?
I think the excessive lobo formation.
Yeah, breast lobules are typically rare in males. Doctor changes are what you see. Gynecomastia like hyperplasia can be seen in which population?
I also be seen in female.
Yeah, I guess gynecomastia.
It can be seen in female.
Which statement about gynecomastia is false?
Because,
Some cases resolve spontaneously,
yeah, it's always resolved.
some require treatment. Good. So sometimes requires treatment. Let us go to the next question. This size. I have 60, 70, 90 seconds to answer.
Data content institute. High grade data content institute. Yes. Mm, I think influencing bilateral. So,
Yeah, what is the answer? Mhm.
I'll take C.
Okay, let's see. Yeah, all right. D. Okay. Because, oh, I'm wrong. Both ChatGPT and I are wrong. I think you should, let's try your own now. I don't think it's C, but let's see. Yeah.
Correct answer is D. Okay. Eh, eh, which one is not the correct answer in your own?
That's what I'm looking for. I've not found the correct answer yet. Yeah, C is wrong, D is wrong.
That means that PCC is strong, yeah.
Uh,
That PCC answer is wrong.
yeah, it is wrong. Let's see. Ah, maybe. Yes.
That PCC answer is wrong.
I grade customer insight frequently shows a discontinuous distribution and growth pattern in dots. And low grade if you can shows a continuous distribution. So this requires a
Mhm.
very strong, in-depth knowledge of these shares to answer these questions, which we are going to do right now. So get ready for a very strong, in-depth analysis for DCIs. DCIs. Um,
Hmm?
let's look at this. Um, hmm. This size requires us to look at this. I'll look at this very well first before I come back to look at this. This is two. This is two. Let's see. What's the name, please? Okay. So are you ready?
Yeah.
So what is this? Can you describe this? Are you ready?
Okay.
Can you describe this?
It's a new plasma
Hmm?
in terms of
Are you feeling sleepy?
yes, so but I want us to do like 30 minutes more.
This this topic is a huge one, but let's see. The number of
Hmm?
slides, if you have to finish all these slides, and they are much. Not too
Okay. Let's finish it.
You have to really, really understand it because you know
Definitely.
this is a very important point.
Monomorphic period of neoplastic epithelial cells.
Especially if you're going to practice abroad, you cannot but know this science. You're going to meet it again and again and again. So let's look at it. What is this?
Hmm?
What is this?
The arrows. That's classification.
What is the whole of this structure?
The whole of the face, epithelial proliferation.
Is this here?
Epithelial, then interspersed by cribriform species.
Are you know that?
The as in interspersed by cribriform species. The
Mm.
epithelial proliferation is interspersed by cribriform species,
So
and is growing within a duct.
is this science or not?
It is
What kind of this is? Low grade or high grade?
low grade.
Why?
Eh, just minimal pleomorphism
Yeah, so it doesn't have
and mild ATP.
no prominent nucleoli, no common
Mm,
necrosis.
mm,
These cells are monomorphic. They are confined to the
mm,
ductal lobular system. They are created from architecture. So they are small to round oval nuclei with minimal polymorphism. Inconspicuous nucleoli, no mitotic activity. Nuclear grid. They have small bland nuclei,
mm,
no nuclear contours. They have an even chromatin distribution. Nerve architecture is cribriform pattern. They have regularly spaced round holes known as fenestrations within the neoplastic epithelia. Okay, these round species are, okay. I think that's all. So, what kind of classification will this in radiology?
mm,
Linear or fine classifications, micro classifications,
mm.
visual
Okay.
or fine. You will not see when you see coarse classifications that are distributed all over, that's benign. But linear calculations or fine calculation of pleomorphic um are fine. Okay. So that's it. So look at this. So this cell is composed of monomorphic cell population with low-grade nuclei forming round cribriform species. Secretions with membrane fragments can be nidus for classifications. So sometimes they have secretions here. These are nidus for classification that can be detected on mammography.
Mm-hmm. This
So
one has necrosis.
what would be the what would be the IHC profile?
It's still ER positive now.
Yeah. What of BCL2? HER2 negative. Those are lumina A. Most of them are lumina A. They're HER2 negative. What of P50?
Okay.
Positive or negative?
Negative. Negative.
No,
No.
wild type pattern. Wild type is what is the negative. Here 67, low or high. Here,
Okay.
here 67, low or high.
It depends on whether it's low grade or high
I
grade.
mean for the low grade one.
It's low proliferation is low.
How do you differentiate it from ADH? ADH will be less than
Mm.
2 millimeter on your ruler. Okay. So how will you differentiate it from collagenous fibrosis?
Collagenous photolysis. Histochemistry. What else?
Do you remember
This
collagenous?
is the darkness basement MP. Okay, so we can do P63 then. Have you?
I mean collagenous ferrulosis. How do you differentiate it from collagenous ferrulosis?
Okay.
How do you differentiate it from collagenous ferrulosis? Do you remember collagenous? What do you know what's collagenous ferrulosis?
Yes.
What was it?
Collagenous you have what look like spaces within the ducts too. But what happen? Some of the spaces can have secretion.
Ferrulosis. Let's look at collagenous ferrulosis here. Oh. It's a mimicker of breast neoplasia of valves and recognized it may help to prevent overdiagnosis. So collagenous ferrulosis is a benign incidental microscopic finding seen in breast tissue. It is characterized by presence of small spherules or basement membrane. These are spherules or basement membrane material and collagen surrounded by dual population of myepithelial cells and epithelial cells. Let's see the pathology outlines. Let me see if I can quickly look at some pictures of collagenous ferrulosis if we can find it. Though. Yeah, is it collagenous ferrulosis? This is it. Benign proliferation of luminal and myepithelial cells. The cribriform pattern is formed by true lumina and pseudolumina that surround basement membrane material. This pseudolumina that doesn't have myepithelial cells surrounding it. This is collagenous ferrulosis. So the pseudolamina formed by myepithelial cells are filled with basement membrane material. It is pseudolamina formed by myepithelial cells. These are filled with basement membrane-like material, which can have a loose fibrillary texture or thick peripheral cuticle. They have so this what is pseudolamina? The pseudolamina has a texture, a loose fibrillary texture or thick peripheral cuticle. Okay. Even when the central area appears empty, they have this fibrillary cuticle or texture surrounding it. That's for the, in contrast, the apical blebs can be seen on luminal cells lining the true lamina, the lumina. This is a true lumina lined by epithelial cells, and you can see apical blebs, apical blebs, apical blebs. If you look at, okay, this is the pseudolamina lined by fibrillary or thick peripheral cuticle. Apical blebs are lining the true lumina, you know. Collagenous, sometimes it involves other lesions such as intraductal papilloma. The epithelial cells of the papilloma surround fibrovascular cores. consisting of stroma and blood vessels. Okay. The epithelial cells of collagenous fibrinosis surround basement membrane-like material. So you see them, they surround basement membrane-like material. Collagenous fibrinosis basement-like material produced by the epithelial cells can take on different appearances. In case the material appears mucinous, this mucinous appearance or fibrillary, some areas have a targetoid pattern like here, different patterns. Both collagenous fibrinosis and cribriform DCIs have a fenestrated pattern with rounded spaces. However, unlike DCIs, many spaces in collagenous fibrinosis are filled with basement membrane-like material. So when you start seeing basement membrane-like material, in what you think is DCIs, in the thinking of collagenous fibrinosis, they're surrounded by my epithelial cells, with smaller nuclei and scant cytoplasm compared to luminal cells. Collagenous fibrinosis, the pseudolaminar and collagenous fibrinosis are lined by P63 myoepithelial cells. Okay. Myoepithelial cells are also present in the periphery. Luminal cells show low molecular weight cytokeratin positivity. Okay. But so the thing is this, it's actually the pseudolaminar surrounding the collagenous fibrinosis membrane lamina that are stained with P63. The real luminal cells are the one that show secretions and show cytoplasmic blebs. Those ones lack P63, cytokeratin positivity. So you see, these will be luminal blebs. There will be negative for P63 or cytokeratin positivity. Apical blebs project to the true lumina here. Okay. So the P63 will be present at the periphery and also be present in the pseudolaminar lining the basement membrane-like material and be negative with the true luminal cell, so you have apical membrane blebbing. Dr. carcinoma in situ cribriform pattern. Cribriform DCIS forms lumina with rigid, punched out spaces, like here, surrounded by cells that are polarized towards the center. Okay. The luminal spaces either empty or contain secretions. Okay. Dr. carcinoma inside to P63. In cribriform DCIS, normal P63 myoepithelial cells are present at the periphery on the basement membrane. The lumina are formed by P63 negative tumor cells. Luminal tumor types, the luminal type tumor cells are uniformly positive for A13 red cytoplasmic immunoreactivity. So the way, if you do A13/P63 testing, remember P63 stands for my epithelial or basal-like cell. So it's remember that normally, CDCIS will lack P63. Okay. Let's see if we can find a picture of that. It's going to be negative for P63. No, P63. I want to look for P63. P63 will be negative in this size inside the lumina of this size, but it's going to be negative in the inside of this size, but it's going to be positive in the outside, showing that my epithelial cells are preserved. Trying to look for P63 IHC screening for you. See, yeah. So the thing is this, for DCIS, from DCIS, for example, collagenous spherulosis, the way you will know is that PCT3 will be positive on the outside, but negative on the inside. Unlike in collagenous spherulosis, where the PCT3 will be positive in the pseudo-luminal spaces, but negative in the true luminal species that normally have apical blebs. Maybe let's quickly finish up this. Adenoid cystic carcinoma. Adenoid cystic carcinoma invades as well circumscribed nest of cells with cribriform pattern formed by true lamina and pseudolamina. These tumors form masses that diffusely infiltrate into the surrounding breast tissue. In adenoid cystic carcinoma, the epithelial-like cells are positive for PCC3 and surround basement membrane-like material as well as form solid areas. Luminal-like cells of adenoid cystic carcinoma are negative for PCC3 and form small true laminas. So luminal cells are negative, while the basal cells around the membrane-like materials. I think the major challenge we have is differentiating adenoid carcinoma from vaginal stenosis. Vaginal stenosis of a lobular neoplasia, creating a complex cribriform pattern that can be mistaken for DCIs. The discohesive pattern is best seen in areas away from the collagenous spherulosis. So it can complicate lobular neoplasia. Collagenous spherulosis and lobular neoplasia. The combination of monomorphic cell population of lobular neoplasia with a cribriform pattern of collagenous spherulosis closely mimics cribriform DCIS. The frequent presence of lobular neoplasia in surrounding breast tissue where it is more easily recognized. The important clue to correct the diagnosis. So this is collagenous spherulosis and lobular neoplasia. I'm going to that now. So here the lesion can be recognized as collagenous spherulosis because the species are filled with tubular material and lined by eosinophilic cuticle. The cells of lobular neoplasia are between the species and are monomorphic and rounded with occasional small gaps discernible between cells. The reason of collagenous spherulosis can be confirmed by demonstrating PCC3 epithelial cells lining the pseudolamina and the periphery of the involved species. The neoplastic cells are PCC3 negative. Two populations of cells are evident. The epithelial cells lining the species show weak E-cadherin positivity due to cross reactivity with P-cadherin. Between the species, the lymphatic lobular neoplasia is negative for E-cadherin. In contrast, these cells will have strong membrane positivity for E-cadherin throughout. Sometimes you may have collagenous spherulosis involving tubular neoplasia. So this is collagenous granulocytes. Collagenous are aggregates of eosinophilic fibrillaries or hyaline spherules, surrounded by the inner layer of myoepithelial cells. Collagenous granulocytes has the characteristic penetration of cribriform materials due to myoepithelial cells surrounding eosinophilic hyaline material. 999999999. Vaginal spherulosis. This is introductory papilloma in fibrovascular core. 000. Associated with vaginal spherulosis. Surrounding areas show the typical fenestrated pattern. The hyaline membrane-like material within spaces. There's variability to the cells within the proliferation due to flattened epithelial cells. Surrounding the cribriform spaces. Pseudolamina. As luminal cells forming through lamina. Abdominal cells forming through lamina.
Hello?
Okay, are you there?
Yeah.
I've been trying to see how to differentiate between collagenous spherulosis, DCIS, and adenocytic carcinoma. I think I've seen enough. It's not easy, but at least I picked up some clues. What is the hallmark of adenocytic carcinoma? How do you suspect it in a diagnosis? Is that triple negative? Don't forget. And then it's a kind of basal cell cancer of the breast with good prognosis. So you do EFA, CK56, EGFR positive, and then you have to do c-kits. C-kits, generally positive. They will say two distinct tumor population. The luminal cells are going to be positive in some areas. Just a minute, please. Okay, so c-kit is positive in adenocytic carcinoma. Okay. Adenocytic carcinoma, I think we are done with this. Good. Collagenous spherulosis is an incidental finding. Adenocytic carcinoma will be a mass, usually greater than 2 cm. So we are done with collagenous spherulosis for now. Let me go back to this CIS story. So one thing, something actually led us to collagenous spherulosis. It was this expanded description that we looked at earlier on, where we say presence of epithelial cells around basement membrane-like material. There is no neoplastic. So this is DCIS with extensive comedonal necrosis, and is usually associated with numerous classifications that are readily seen on mammography. In addition, periductal fibrosis can sometimes result in mammographic density or an ill-defined mass. These are clustered classifications that are pleomorphic and variable in shape. Either linear or clustered classifications can help. Sometimes you have this fine branching, what we call linear, and branching classifications, and they are correlated with high-grade DCIS with central comedonal necrosis. The pattern of classifications involves the ductal system. DCIS rarely presents as a circumscribed or lobulated mass. The DCIS may involve an expanded ductal space, typically papillary DCIS, and consists of multiple closely arranged ducts with periductal fibrosis or involve another mass forming lesion, such as fibroadenoma. DCIS involving fibroadenoma occasionally detected due to involvement of a benign mass forming lesion, such as this fibroadenoma. Classification is often difficult unless there are more obvious foci of DCIS in the adjacent tissue. It's not clear here, but this is DCIS. Magnetic resonance mammographic. What is MR? MR is sensitive for detecting DCIS, but not specific. Sorry. What is MR?
Hello?
Yes, what is MR? Is it magnetic resonance
Mm.
imaging for breast?
Okay.
As MRI is sensitive for, but not specific. You can detect even small foci of DCIS. CD31. DCIS is often surrounded by small blood vessels. So sometimes CD31 may be positive and form linear or clamp enhancement or magnetic resonance imaging, but it's not specific for DCIS. This gross appearance of DCIS with comedonal necrosis. Numerous ducts are filled with necrotic material. Necrotic material, ducts, necrotic material. With gentle compression, punctate necrotic foci may exude from the tissue. This comedone-like. DCIS is central comedonal necrosis. What grade can you see central necrosis in DCIS?
Okay.
In all grades. However, it
Okay.
is more common in DCIS with higher nuclear grades. Remember, this is a low grade. This is, although the comedonal necrosis will be have more volume actually in high grade DCIS. Look at it, these are low grade DC, low grade nuclei, yet it has comedonal necrosis. This is papillary and micropapillary pattern. They have fibrobascular cause. Globoid cells are present and should not be mistaken for epithelial cells. It's micropapillary, papillary and micropapillary DCIS pattern. In the micropapillary pattern, the micropapillae formed by the DCIS typically have narrow discs. If you look at it here, I remember we saw before that there will be hyperchromasia at the tip of the micropapillary. If you look at it here, the micropapillae, the bases are narrow. If you look here, thick in here, narrow base. you know, narrow basis. It's not very clear, but do you have narrow basis here compared to the bulging tips? The tips bulge, the bases are narrow. The intervening epithelium is flat. The intervening epithelium in between them is flat. The majority have low grade nuclei, macropapillary DCIs. In usual cases such as this one have high grade nuclei, frequent mitosis, like the one we have here. Mitosis, and necrosis. There's some necrosis here. I think here too. This here is papillary pattern. We look at P63 and AE13. In some labs, they combine P63 and AE13. In papillary pattern, this here is P63 is still the myoepithelial cells outside and are present at the periphery, but not present lining the fibrovascular course. If they are present, the BCS will involve pre-existing papilloma. This is DCS papillary pattern. A rare presentation of DCS in nipple discharge. Underlying DCS is generally extensive and has a papillary and micropapillary pattern. Mastectomy is often necessary. This case was associated with bloody discharge. The patient had bloody discharge with DCIs in the discharge listed. Then this is cribriform pattern DCIs. Uniform, the cribriform DCIs forms uniform round spaces oriented toward the lumen. The spaces are oriented toward the lumen. The spaces are evenly distributed throughout the involved duct. Necrosis is an unusual finding in the cribriform pattern. This is solid pattern DCIs. It can be difficult to recognize as it lacks helpful diagnostic architectural features. The main differential diagnosis is lobular carcinoma in situ, LCIS. These cells usually have nuclei of higher grade. And a more cohesive appearance. IEC can be helpful in some cases to confirm cadherin expression. The higher grade, these solid D cells have higher grade, and the nuclei are grade 2 nuclei. Can you classify nuclei in can you do nuclear grading for DCIs? What are the parameters for nuclear grading for DCIs?
This one has prominent, they say TPN, there's prominent nucleoli.
DCIs grade 1 has more uniform monotonous nuclei. 1 to 2 times the size of normal ductal epithelial nuclei. Smooth nuclear contours, distributed file chromatin, inconspicuous or small nucleoli. Matrices are rare. The cribriform, micropapillary or papillary and low-grade DCIs examples. Necrosis is absent or focal, no comedo type. Comedo is very large one. It's indolent and low risk of recurrence after excision. What of intermediate grade DCIs, grade 2? Parameters.
That would be
Minor to moderate pleomorphism, 2 to 3 times the size of normal size. You can compare these cells here to the cells here, that's like 2 times. Okay. Mild irregularity of nuclear membrane, nuclear contours, slightly clumped chromatin. Nucleolide going to be present. I'm looking at this already. I'll call this at least grade 2.
I'll call it like that.
We show cribriform, micropapillary, or solid growth pattern. Solid growth is like grade 2. Local necrosis will be present, but it's not central or widespread. Grade 3 is the one that has chronic necrosis. Marked variation in size, irregularity, prominent nucleoli. Necrosis are frequently present on the solid cribriform. Central common necrosis leads to microcalcifications on mammography. High recurrence and can produce progressive carcinoma when excited. High-grade DCIS warrants more aggressive treatment like radiation and wider excision. So if you say high-grade DCIS, they will radiate the patient. So be careful what you call. The low-grade DCIS, surveillance. Look at the differences in table. For low-grade, local size is 1.5 to 2 times normal. Local is inconspicuous. Chromatin is fine, even chromatin, rare, mitosis, absence of minimal necrosis. 2.5 is the size, for intermediate size, small visible nucleoli, clump, occasional focal. High grade is 2.5 to 3 times prominent nucleoli. The circular chromatin. This is actually high grade. Even though there's no prominent necrosis, the fact that we have prominent nucleoli, vesicular chromatin. Mitotic rate is typical, atypical. It can be common necrosis. And that thing can use low Ki67. It's going to be low in low grade DCIS and high in high grade DCIS. We want to know, is it low grade, is it high grade DCIS they are dealing with. P53 will be mutated in high grade DCIS. Will be wild type in low grade DCIS. Grade DCIS is lumina A and will be BCL2 positive. While high grade DCIS is usually like lumina B, ERO negative, but HER2 positive. And Ki67 will be high. So if you want to report this size, what should you report? Nuclear grid, whether it's low, intermediate, or high. Architectural pattern, presence or absence of necrosis, margins, positive or negative, size and extent of the lesion. Nuclear grid is the strongest predictor of recurrence risk in DCIs. Report the highest nuclear grid seen. Pulmonary necrosis is strongly linked to high-grade DCIs. Low-grade DCIs are generally hormone receptor positive, while high-grade DCIs are more HER2 p53 driven. Nuclear grid drives therapy, so be careful. There's this entity called DCIS clinging pattern. Right, the triple negative and difficult to recognize. DCIS adjacent to BRCA1 associated invasive cancer is only recognizable due to high nuclear grid. The associated lymphocytic infiltrate is commonly seen. This is more difficult, I would say. Non-sclerosing lymphocytic globulitis. T-cell infiltrating normal appearing nodules can mimic DCIS. Clear cell metaplasia. These cells can have clear, foamy, or secretory cytoplasm. The nuclei are generally small and round. This type of these cells can be difficult to recognize in isolation, only if solid pattern is present. These cells with foam cell metaplasia. This type of these cells could easily be mistaken for histiocytes, which is the presence of extensive vacuolated cytoplasm, small dark nuclei. These cells shows extensive central necrosis, which is indication of unusual type of these cells. Hypocrine metaplasia. These cells can have hypocrine appearance with a large nuclei and abundant eosinophilic cytoplasm. Because hypocrine metaplasia gives a monomorphic appearance, it can be difficult to diagnose unless there's abnormal high-grade variants. Crystalloids can appear with square or sharp borders associated with DCIS. Mucin production DCIS. These cells can form mucin, which often calcifies. If a duct ruptures, the mucin can traverse into the surrounding stroma. This mucin should be devoid of tumor cells. If tumor cells are present, the differential diagnosis includes invasive mucinous carcinoma. However, if it's floating without mucin, that could be these cells are ruptured and mucin extravasated into the stroma. This cells heterogeneity. These cells can show marked heterogeneity in morphology and tumor markers. In this doctor space, there is one population of cells with high-grade nuclei and adjacent to another population of cells resembling low-grade CI, this SCIS, with low-grade nuclei. These cells with pagetoid spread. These cells can grow into ducts and lobules. It generally overgrows and replaces normal luminal cells. Pagetoid spread preserving the overlying luminal cells is rarely seen or only focally seen at the advancing stage edge. These cells involving nipple epidermis are the pagetoid disease of nipple. So we see in nipple, the epidermis located between the basement membrane of the skin and the overlying keratinocytes. So yeah, we see this pagetoid spread. I mean, this is not even clear to me that this is this size. I don't know how this is this size. I had two new positive, but let's see. Cancerization of lobules. It can expand to terminal ducts and expand and distort the incinera of a lobule. The entire lobule may become a single circumscribed space resembling a duct. This is cancellation of lobules, of course, will be HER2 positive. Let's see. This is ER. More than 70% of DCIS express ER. The hormonal treatment with tamoxifen reduces the likelihood of local recurrence. The benefits may be limited to or primarily found in patients with ER positive DCIS. DCIS and LCIS. DCIS and LCIS can involve the same space, unfortunately. So you can see here ECAD hearing loss in the LCIS portion is adjacent to the ECAD hearing positive cribriform DCIS. DCIS involving sclerosing adenosis can be difficult to distinguish for invasive cancer. Important clues to correct diagnosis is the presence of adjacent areas of adenosis without DCIS. The organized arrangement of the involved ducts parallel to one another and often the swelling rather than infiltrative borders. These DCIS involving sclerosing adenosis, microglial cells are generally prominent and readily detected. This thing. Microinvasive carcinoma. There was the A1, species cytokeratin A13. You see the invasive cancer have no epithelial cells, while the DCIS portion has myoepithelial cells surrounding it. DCIS with ADH and high molecular weight keratins. Myoepithelial cells are positive. Let's look at definition of extent of DCIS. The extent of DCIS can be measured on a single glass slide if only a single block of tissue is involved. If more than one block contains DCIS, this method will underestimate the extent and should not be used. So this is the extent of DCIS on one glass slide. But in resection, you have to check the extent of the DCIS. If more than one legal slide is involved, don't measure the extent. In complete serial sequential sampling, the entire specimen is processed in such a way that the location of DCIS can be mapped. The extent is measured as the greatest linear dimension. So the extent of a DCIS is not actually the number of blocks. Is the greatest linear dimension of the DCIs. Greatest linear dimension. If you map it, you can now. So let's see. In the block method, the entire area of DCIS sample as well as the representative tissue from the remaining specimen. The extent of DCIS can be estimated by multiplying the number of blocks involved by the thickness of the section. So if there are blocks, 1, 2, 3, 4. So times 0.4 cm. This method is related to volume as well as to linear extent. So the number of blocks times the thickness of the sections is what you use to calculate the extent of the DCIs. If the size of the specimen is known and this size involves two opposing margins, the size of the specimen can be used to give the measurement of the extent. DCIS margin. The extent of these cells can only be estimated for many reasons. For example, in many cases, this cells is removed in multiple specimens because margins are often positive or close. And this cells is also present in subsequent margin excisions. The actual extent of these cells is more than one in more than one specimen is uncertain. UDH with central necrosis. Florid usual hyperplasia consists of a variety of cell types, conferring a heterogeneous appearance. Peripheral slit-like spaces are characteristic. Central necrosis can be present and is not indicative of malignancy. So UDH cannot occasionally have central necrosis. Take note of that. UDH with high molecular weight keratin. These cells and ADH are generally negative for high molecular weight cytokeratin such as CK5 and 6. Whereas UDH is a mixture of luminal, myepithelial, and intermediate cells with a heterogeneous pattern, as in this case. So CK5 is positive in UDH, but negative in DCIs. ADH lacks sufficient quantities and qualitative criteria for DCIs, quantitative and qualitative criteria. In this case, the lesion is small. There is streaming of cells across spaces. And the spaces are not completely filled. Therefore, ADH is favored. ADH and LCIS, a combination of ADH forming cribriform spaces and arches, and the monomorphic cells of LCIS involving the same species can closely mimic DCIS. IHC for e-cadherin can be helpful to identify mixed populations. DCIS versus LCIS. It's only proliferation of small random monomorphic cells with a discohesive appearance. Suggests LCIS. However, there is necrosis and possible minute cribriform spaces. IHC for e-cadherin can be helpful to determine if this lesion could be classified as LCIS or DCIS. There's an entity called pleomorphic DCIS due to solid pattern, high nuclear grid, and central necrosis with calcifications. The LCIS and the associated invasive lobular carcinoma are negative for E-cadherin. The LCIS are negative for E-cadherin. Let's see. Gynecomastoid hyperplasia, this is what they're talking about. Gynecomastia or gynecomastoid hyperplasia consists of small ducts without lobule formation. The hyperplasia has a pattern of tapering and small abortive papillae that should not be mistaken for micropapillary DCIS. Collagenous spherulosis is a proliferation of luminal and myepithelial cells. The later cells lie circumscribed spaces that are filled with basement membrane-like material. We looked at it earlier. Radiation atypia cause enlargement of nuclei in scattered cells, usually located in atrophic duct. The cells should not contain or be filling spaces or forming architectural structures. In some cases, it may be difficult to distinguish from radiation atypia from recurrent DCIs. Invasive carcinoma. Invasive carcinoma can include circumscribed nests of cells. The carcinoma was mistaken for DCIs. Useful clues to correct the diagnosis are the surrounding desmoplastic stromal response and the haphazard arrangement of the tumor nests. LVI. Both DCIs and LVI involve circumscribed spaces. and may not elicit stromal response. Multiple involved lymphatic spaces are present in lymphatic pattern running between normal and uninvolved lobules. The branching complex shapes are useless. Just for recurrence. This is solid papillary carcinoma. The circumference of cells surrounding fibrovascular cores may or may not be associated with myepithelial cells. If frank stroma invasion is not present, metastases are rare, and clinical course is similar to PCIs. DCIS, papillary pattern, P63, and cytokeratin. UDH with central necrosis. Aplasia typically is florid. Yeah. Necrosis is most common in aplasia in a nipple adenoma and can be mistaken for carcinoma. UDH central necrosis can be an alarming finding. IAC for high molecular weight keratins. An ER to confirm a heterogeneous benign population may be helpful. Like CK56. It's a micropapillary pattern with low nuclear grade, as well as central necrosis. The DCS grows as true papillae with fibrovascular cores, as well as micropapillae without fibrovascular cores. Most cases of these cells have multiple architectural patterns. Classifications may be evident near the margin of the specimen. Margin. Margins may be difficult to evaluate as this size is rarely visible grossly and ink may leak into tissue cracks. In this case, the true margin appears to be distant from the DCIs. However, these cells appear to be close to an ink in tissue crevice. Agitoid spread. Gynecomastia hyperplasia is often associated with epithelial hyperplasia with tapering papillae or small abortive papillae. On the background of hyperplasia, the proliferation lacks architectural atypia of micropapillary DCIs. Uniform pattern with microacini. DCIs heterogeneity. Uniform pattern with high nuclear grade. Is intermingled with solid DCIs with low nuclear grade. ERPR had two new ways to the heterogeneity. DCIs involving the papilloma. DCIs cubiform pattern. Micropapillary pattern consists of narrow base elongated papillae extending into duct spaces. Papillae are solid without fibrovascular core. DCIS morphologic heterogeneity. Micropapillary pattern. Papillary type. Invasive carcinoma. Invading as roundedness can be mistaken for DCI solid pattern. Compressed tumor cells at the periphery can be mistaken for epithelial cells. A few blood vessels are positive for calponin, but no epithelial cells are present. Two, heterogeneity. Solid papillary carcinoma. Shaped like DCIs. Solid papillary carcinoma. This is just the correct name. LVI. This foci of LVI was misinterpreted as DCIs. Note the adjacent uninvolved lobules and more obvious lymphatic involvement at the periphery. It is dangerous. Correct invasive carcinoma in the chest wall can be taken as DCIs. This is collagenous fibrosis, random epithelial cells filled with basal membrane-like material and may appear collagenous, mucinous, flocculent, or a targetoid pattern. Exactly, so cuticle often lines the spaces. Fringing pattern DCIs. You can have targetoid spread in the breast. That hearing. That brings us to the end of like looking at this DCIs. Let's quickly look at this before we round off. Let's look at this says the clonal proliferation of malignant epithelial cells confined to the ductal lobular system of the breast. Critically, this cell does not invade the basement membrane, and that distinguishes it from invasive breast cancer. This cell is a direct precursor to invasive carcinoma, but only a subset progress. Synonym include intraductal carcinoma, no longer used. CIS shows there's many genetic alterations with the invasive breast cancer. Common mutations are PIK3CA, TP53, GATA3. Low to intermediate grade DCIs gains 1K, only 16K. Hormonal profile 70 to 80% are ARPR positive. A2 expression overexpression occurs in 30%, more than in invasive cancers. Triple negative DCIs is rare, only 5 to 10%, but may progress rapidly. My epithelial cells epithelial changes, lots of um, um my epithelial changes, lots of displacement of my epithelial cells which may impair the ability to maintain basement membrane integrity is a key. Loss or displacement of my epithelial cells is the key toward invasion. 13 to 50% of women at autopsy harbor DCIs. And this accounts for 20 to 30% of breast cancers detected on screening mammography. Demographic. Most women, mostly are women, rare in men. When present, it's often retrieval areola with nipple discharge. Increased incidence increases with age, doubling around 40 to 80 years. Histopathologic features. Look at the architecture, the cytology, the necrosis, the calcification, the extent, epithelial cells, special features. Architecture, cribriform, solid, micropapillary, papillary, clinging, and mixed patterns are common. When you say clinging, this says, what does it really mean? Clinging pattern consists of cells with hybrid nuclei lining spaces without filling the space or forming architectural structures, just clinging to the wall and almost falling off. These cells with other architectural patterns is usually present in the adjacent tissue. So clinging pattern architecture, mixed patterns are common. Cytology, monomorphic cells for low grade versus polymorphic nuclei with prominent nucleoli for high grade. Necrosis is comedonecrosis. Necrosis. Central necrosis in classifications is a hallmark of high grade DCIs. Classifications can form on secretions or necrotic debris, major fluid or mammography. Extents measured as volume of breast occupied. Small, less than 2 cm, average 2 to 3 cm, large, greater than 3 cm. So you want to measure the extent of this CIS is the volume of breast occupied. So is it less than 2 cm, average is 2 to 3 cm, and large 3 to 3 cm. Epithelial cells are usually present around ducts, absent in papillary cores and in invasion. So let's look at it again. For my epithelial cells, this cell is usually present around the ducts, absent in the papillary cores and in invasion. So you can confirm that by doing ICP63, tamponine, SME. Hello, can you hear me now? Hello? Let me share my screen again. Hello? Can you hear me now? Special features include apocrine, clear cell, foamy cell metaplasia, mucin production, purgatory spread into nipple epidermis associated with HER2 positivity for the nipple spread. Greater than 90% are asymptomatic, detected on mammography, typically microcalcifications. Less than 5% are present with palpable mass or nipple discharge. Budget disease of the nipple is just 1%. Yeah.
Hello, Juno. Can you hear me?
Yeah, can you hear me now?
Yeah, I can hear you now.
So this is a very low. So because we do not believe at times because of the estrogen exposure.
Maybe we should just solve question on that BCNS.
We're almost done. We get from Christianity. You are tired. Okay. Because this size I will almost get there now. What's the prognosis for this size? 95%. Untreated DCIs have 1% per year risk of progression to invasive carcinoma. Recurrence risk after treatment is 50% for DCIs, 50% for invasive carcinoma. Risk factors for recurrence: young age, high nucleic grade, close or positive margins. The IHC, ERPR is 7 to 80%, HER2 is positive in 30%. And if there's purgatory spread of DCIs to the nipple, usually HER2 positive. E. cadherin is positive in DCIS. That would be used to differentiate it from LCIS. Epithelial markers, they have intact epithelial marker that help to exclude invasive carcinoma or microinvasion. CK56 is negative in DCIS and positive where? What do you use CK56 to do in case of DCIS?
Mhm. Invasion.
No, to differentiate between UDH and DCIS. Sometimes UDH can resemble DCIS. You know, sometimes diseases refuse to read textbook. It will look very pale. Somehow, the cells will look polymorphous, but we still not be so clear. Understand? So in such instances, you need to use CK56 to differentiate between UDH.
Because the capacity is saying my epithelial cells or what?
It's high molecular weight keratin. It can still my epithelial cells somehow too, but it's beyond that. So if you have molecular weight keratin, you look at the
I
PDF
know. I said, why do you use?
because it stains, the cells of these cells are neoplastic somehow. But
Usual doctor pathology.
the plastic, so I think they can pick up CK56 for some reason. It's a molecular weight cytokeratin expressed in basal myopithelial cells. That makes sense. Benign lesion like UDH typically shows mosaic pattern of CK56. ADH and DCIS lack CK56 expression, helping in differentiation from ADH, UDH. The,
Mm-hmm.
the inside is neoplastic, so triple negative breast cancers may express CK56 like basal, like we know that already. Mm, let's look at the images now. Look at these images here. CK56. This is probably UDH.
Which one?
This one here.
Okay, on the left.
You see, it looks like this size. Somehow low power cribble forming type of when you now do CK56 and it's kind of well lit compared to CK56. They are thinking of UDH. It shows
Okay.
mosaic pattern. Let me see. This is not this is ER or PLR. Let's see. Things like this. Mosaic pattern also. This is a mosaic pattern. So UDH. Okay, let's not devil it. So let's go to this histology pattern. So have the cribriform pattern, the papillary pattern. What will you see in the papillary pattern of DCIS? Papillary macropapillary pattern.
The vocabulary call without central epithelial cells.
Yeah, there will be central species, but what will you see in papillary micropapillary pattern? Let me show you this picture. Let me see if I can find it for you.
Man, papillary we have microvascular core, micro, my,
Yeah,
uh,
but there's another thing you will see in papillary.
the other one will not
If you look at this papillary pattern, there's something you will see in papillary pattern. Let me see if I can find. Very good. In papillary pattern, this is both papillary and micropapillary. Look at this is papillary because you have fibrovascular core. This is micropapillary. Then the micropapillary, when you zoom higher, you will see that their bases are narrow. They have narrow bases, but plump ends. The ends are enlarged, the tips are enlarged. and may have mitotic figures. Like this case, no, not all the tangential, but the tips are enlarged. You can see broad-based bulbs, narrow-based, now you're thinned out. And this broad-based area may be hyperchromy. You have hyperchromasia, like in one of the areas earlier.
Mm.
So
Okay.
that's for recognition, because a lot of times to be true, tell you the truth, then solid type can completely fill the dots. Remember, what is the nuclear grading for, what are the parameters for nuclear grading? What constitutes grade 1 DCIS?
My geomorphism,
To 1.5 to 2 times size, no visible nucleoli, no common mitosis. What of grade 2?
okay, what is that? Tell me.
2 to 2.5 size, small nucleoli, occasional mitosis. What, and there's some chromatin clumping. What is the hallmark of grade 3? What are the hallmark of grade 3 DCIs? Some major things that make you know that this is high grade DCIs.
Prominent nuclear
Prominent nucleoli. What about the chromatin?
clump.
Vesicular chromatin.
Okay.
What is vesicular chromatin?
You could see through now.
Yeah,
Is
like you see this vesicular chromatin and prominent nucleoli. Clearly, like open chromatin. This is essentially solid high grade. What other thing is a very classic association with high grade DCIS? Comedo type.
microinvasion.
No,
Okay.
microinvasion is already carcinoma. What is microinvasion? Define microinvasion.
Yeah, you just see some cluster of cells within the stroma,
No. Less than,
invading the stroma.
less than 1 millimeter of extension from the DCIS, of invasion from the DCIS. C. 1 millimeter. If the invasive component is more than 1 millimeter, that's frank carcinoma. So this CIS microinvasion is actually TPT1 MIC. It has to be less than 1 millimeter, less than or equal to 1 millimeter in greatest dimension of the focus of invasion. Okay, let's see if we can see pictures. Show relevant pictures. Relevant pictures.
I want us to finish.
You can see this. This is DCIS. You can see this area is breaking out and seems to be invading the stroma. You can see these small cells invading the stroma. So when you measure with your ruler, it should not be more than 1 millimeter. If it's more than 1 millimeter, that is invasive ductal carcinoma.
How do you do that measurement?
You just put this transparent ruler under to measure it. Some microscope have ruler, but not all. If it doesn't, your own doesn't have, just put this ruler under and measure. So
Under that point, Abi?
yes, on top of your slide. Next time
Oh,
just use
okay. On top of the slide, where the invasion is, Abi?
from you put on top of this glass slide. No, it's transparent ruler, so you're gonna see the lines, of course, will be magnified.
Okay. And you just put it on top of it on
Yeah,
where the invasion is.
Yes, from you measure from here to here. If it's less than or equal to 1 millimeter, that's microinvasive carcinoma. If it's more than 1 millimeter, that's frank cancer. We then come back to. So why do we need to differentiate between high grade DCIs and low grade DCIs?
Management now, the treatment,
What is the treatment?
excision for what's it called now?
Both of them have excision. What would the difference?
And then also maybe the margin you're going to leave. All those ones.
There's radiotherapy for high grade,
Okay.
radiation therapy. So if you call low grade DCIs high grade, the patient will get radiation therapy. And if the thing that is covered, that may not be good. That will be over treatment. If you call high grade DCIs low grade, you call low grade DCIs, so high grade DCIs low grade, patient will not get radiation and the disease may progress to cancer, and that can be an issue. So that's why it's good to be very specific and be careful in making the diagnosis of high grade. The nuclear grading is the most consistent and most helpful. And you also have to find out if there's microinvasion or not, or if it's frank cancer. So in the area of microinvasion, also P63 and smooth muscle, putting and smooth muscle active will be negative.
Yeah. Come.
Then cytokeratin.
Come.
Cytokeratin can also be done.
Come, let me help you. Come.
Cytokeratin and myopathy markers are very helpful when H&E assessment is difficult.
Sorry, what do you say? Which IEC do you do at microinvasion?
Remember that in microinvasion, the way you know invasion is absence of P63. There will be no P63 markers at the area of invasion. Like if you look at those tumor cells we saw here. Let me see. You see, this is supposed to be microinvasion. Let's assume this is microinvasion. When you do P63, smooth muscle mycin heavy chain, okay, you will see that these P63 and smooth muscle mycin chain will be positive here. Sorry, what's the meaning of this? What is this called?
We go here.
What is it? What is it?
That brown now.
What is it? I read it again. I read it again.
Oh, that brown and purple. I think we know fit it.
I read it again. 1, 2, 3.
Look at the base of the two.
Perfect. That's fine. So sorry. So look at this. So this is if you look P63 and slow measure and by particular markers, it will highlight the DCIS, but it will not highlight the microinvasive component. Don't forget that you have some companies do A13, P63 together, or can do it separately. A13 cytokeratin, of course, will highlight both of them. Anyway. We have to always look out for signs of microinvasion or pure invasion. If it's more than 1 millimeter, then that's cancer. Axillary lymph node metastasis is rare, but can occur in this CIS, 1 to 2%. Let me ask you this question. As a pathologist, if you diagnose this CIS with microinvasion, what is the implication of that diagnosis for the patient?
The patient will be treated as invasive carcinoma.
No, of course,
So mastectomy.
yeah, but even without microinvasion, the person will be treated with mastectomy. The difference is this: the patient will be after the mastectomy, the patient will be because after mastectomy, they send the breast to us, we examine it, we diagnose DCIS. That's all. But if you say DCIS plus microinvasion, then we call the patient to come back for what? Sentinel lymph node biopsy. They'll start looking for signs of metastasis. Who knows if that microinvasion makes you to start thinking of possible metastasis. Okay. So what that time do you do lymph node? You don't do sentinel lymph node all the time, biopsy. When else do you do sentinel lymph node biopsy if you have high grade DCIs? So high grade DCIs has implication in the sense that the patient will get radiotherapy. Also, the patient will get lymph node, sentinel lymph node biopsy. There's also what called extensive DCIs. The extent of DCIs is important. Remember, when you want to measure DCIs, you were talking about grossing. Do you know how to gross DCIs?
Okay.
Okay, when you
Tell me.
gross DCIs, you have to measure the extent of DCIs. Now, this is the breast
Instead
duct.
of the tumor, okay.
Here is the DCIs, for instance. If it is only on one slide, you measure the largest diameter. That's the extent of DCIs. But if it's on multiple slides, that's why in the US here, we map breast. Again, DCIs. You have to map it. I took this section from it to take all these sections, and then all these sections, you now measure the thickness of the number of blocks you took, multiply by the thickness of the sections you took, which is usually 0.4 millimeters, 0.4 centimeters or 4 millimeters, to give you the extent of the DCIS. Look at the blocks you took. So that'll give you the extent of the DCIS. Okay. And sometimes the DCIS can come from one margin to the other. We ink margins. If this is blue, this is black. So you measure the diameter from blue to black roughly. I can give you the extent of DCIS. Sometimes we measure the cavity space. So you want to measure how many the consecutive sections of the map will help you to know the extent of DCIS in the patient. Understand? So it's difficult to estimate, but it's necessary to estimate it. This microinvasion, does microinvasive DCIS have a worse prognosis compared to normal DCIS?
Yes.
The answer is actually no. Even though it's microinvasive DCIS, it's the same prognosis with DCIS, and they are both excellent prognosis. And they have all that have excellent overall survival rate. So microinvasion is less than or equal to 0.1 cm. And this is always associated with high-grade DCIS or comedonal necrosis. Okay, let me see. So now for the text in back to our question text. So we talk about DCIS confined to the ductal lobular system without invasion beyond the basement membrane. is 15 to 20% of breast cancer detected on mammography. Is considered a stage 0 lesion. DCS is highly heterogeneous. Molecular analysis features strongly correlate with nuclear grade. What will be the IHC profile of low-grade DCIS?
ER, also negative, then low proliferative index, low KI 67.
BCL2. So low grade will be lumina A type of breast, BRCA profile, then BCL2 positive, P53 will be wild type, KI67 will be low. What of high grade DCIS based on what we have here?
ERPR negative,
Right lumina B, ERPR negative, HER2 amplification. What else?
high KI 67, high proliferative index.
The P52 by expression and all that.
Mm-hmm.
High grade DCIS is often necrotic, common necrosis, and HER2 new P53 driven, while low grade DCIS is hormone driven and lacks necrosis, but that's not always the case. So UDH can also have central necrosis at times, and that's why you need CK56 to help you differentiate at times. Historical misconception. Many years ago, people thought that
High grade is good discontinuously.
that DCIS has this continuous pattern, in the sense that there can be skip lesions. Do you understand? That instead of these two, this cells will grow here, then give space, grow here, then give space, grow here. That makes it difficult to actually estimate the extent of these cells. But with better imaging, we now know that that's not true. These cells is always continuous. That's why we have the capacity to be able to determine the extent of the DCIs. So it's never, DCIs is never discontinuous. Let me see. So people actually thought before that the high-grade DCIs grows discontinuously and low-grade DCIs grows continuously. Corrected 3D imaging studies show that high is actually the reverse pattern, that high-grade DCIs has continuous line of ducts greater than 90% of cases, while low-grade DCIs has this continuous pattern with intervening normal ducts. So there's a kind of inverse of the cases. So if you look at the question we saw here,
Yeah, I think I might need to go now.
is it?
I need to go. Should we round up?
Okay, we're almost done. Okay, no problem. I will upload the videos later, but when we come tomorrow, we can review. When are you gonna be free and not be on break?
Hmm?
When are you gonna be free and not be on break?
Free. Well, the time I'll still be free will be like the time today, like this same 2 a.m.
Oh,
But I don't know if I'm able to rest very well when I get home. I might call you. See what's up to know. That's if I'm able to rest properly.
but let me release you.
Hmm.
Later. Thank you very much.
You're welcome. You guys, you're welcome. Wow.
Okay, sir.